So since it's a webinar, the Q&A will work and the chat won't for the purpose of questions, okay? But you're very welcome to put your questions and comments on the Q&A. So welcome to the GICS Radiology meeting. We are very happy to have here Professor Henrique Lederman, who is a pediatric radiologist. And with me, I have Leonardo Tonella Romero, who is a pediatric surgery resident in São Paulo, Brazil. We also have Professor Hafiz Abdel Hafiz, who is our GICS president-elect, and will also present another case. And also, we are very happy to have Professor Anand Shan and Professor Mohammed Shalabi, both as moderators with me within the session. So without further ado, we will present two cases today. So I will start and please, Leonardo, the floor is yours.
So, hi to everyone. As she said, my name is Leonardo. I'm a fifth-year resident, and I will present this case report with the supervision and assist by Professor Dr. Simon. So, here we have a kid, a male kid, 11 months old, with an abdominal distension for 4 months, a palpable abdominal mass on the left, no pain, no hypertension, no urinary or intestinal symptoms. Born with 34 weeks, unremarkable neonatal period, no comorbidities or previous surgeries, no allergies or chronic medication use. And at the physical exam, a healthy kid with good general condition, a little bit pale, well hydrated, and afebrile, breathing comfortably, no palpable lymphadenopathy, cardiovascular and respiratory examination unremarkable, with a globose non-tender abdomen, bowel sounds present, abdominal circumference 45 centimeters, with a firm, well-defined, painless mass in the left hemiabdomen, 9 centimeters below the costal margin, and normal male external genitalia, tests in the scrotum, extremities with good perfusion without edema.
Okay, Leonardo, stop there. Okay.
Yeah.
The idea, people, is to discuss this case as a clinical real life. Okay, therefore, go back one slide, please. You can type on the chat, or if one day people will be available to open for people the camera for people to talk. Okay, we have an 11-month-old boy with an abdominal mass in the left flank. And next one, Leonardo, clinical examination, fantastic. Physical exam. He's looking very well. Next, you see, everything is okay beside the mass. Now, what we are going to do with this patient? Okay, that's question number one. Who wants to answer question number one? Okay, you can ask clinical, lab examination, image examination, whatever you want. This is a major real-life discussion.
Leo, you can put the forward slide, please. And that's exactly the, go ahead. So what are the hypotheses? Yeah.
Okay, let's see what people is going to write.
So I'm seeing, in the Q&A section, one of the attendees has said ultrasound abdomen. Two of the attendees have said ultrasound abdomen.
Okay, ultrasound abdomen. Okay, now question for this. Hold on a sec. Hold on a sec. Ultrasound abdomen, plain or you want with Doppler image? The attending there asked the question.
With Doppler, they say.
With Doppler, okay. Now, any lab examination you want to ask?
They said, depending on ultrasound, to decide tumor markers after.
Tumor markers. You don't want to know. You don't know if.
CBC,
Yeah.
urine, yeah.
Okay. The regular examination plus an inflammatory change like PCR or SED rate, plus you are going to see the image and decide if we need to go for further thing. Okay, Leonardo. If the hypothesis is an abdominal mass to be defined by the ultrasound. You have ultrasound, Leonardo?
I have. It's a little bit further, but here we have, just for the hypothesis, we have the
Okay,
victim mnemonic.
okay. Now we are going to discuss the so-called victim. Victim is a nickname, or is a, I don't know in English how to say it. It's a several defined differential diagnosis. When we have an abdominal mass or anything, we can use independent of the image to think or following the image to think. V as a vascular lesion, E as I as inflammatory infections, C congenital that could be collagenal, cardiac lesion, T traumatic tumor. The other one, I normally use the first I as inflammatory infection and leave the last one as idiopathic, metabolic, miscellaneous, and metastatic. There is another one. Okay, therefore, this is the broad differential diagnosis that we need to use every time we see something. Do you have the image now, Leonardo?
I have it, but before I just put it the hypothesis here
No,
for
you see, the hypothesis will go after the image, okay? If not, we are going to do
I'll
everything.
skip it very fast, and then we have the ultrasound here.
Okay. No, we want the image. We don't want the report.
We don't have it. It's from the
another hospital. We don't have.
Oh, it's a pity.
Sorry.
Okay. Left kidney. Go ahead, Leonardo. Read the
So
report.
we have here the abdominal ultrasound with Doppler. So we have the left kidney demonstrating a large heterogeneous solid mass, predominantly arising from the renal parenchyma. The lesion presents heterogeneous echogenicity with hypoechoic areas associated with cystic necrotic areas. At Doppler, demonstrating internal vascularity. The lesion causes distortion of the normal renal architecture with poorly defined residual renal parenchyma. And on Doppler evaluation, we have the renal vein pattern, such as the vena cava, with no evidence of thrombus.
Okay, stop there. Who wants to send one hypothesis going back to the differential diagnosis that go back one now, Leonardo, with all the vascular, everything you have? Okay, who wants to say something? Vascular, go further.
Put it all, Leo.
Put it all, okay. So for V as vascular, we can think about some malformations, some, for example, hemangioma. It's a little bit rare, but we can think about it. We can think about pseudotumoral mass for renal vein thrombosis and also for hematoma, but no reported trauma in this case. So a little bit less likely for this case. And for infectious, we can think about a renal abscess, a pyonephrosis, but again, no fever, no urinary symptoms to think about infectious hypothesis. For C, for congenital, we have a multicystic dysplastic kidney, a congenital hydronephrosis, which is very common for UPJ obstruction, for example, a simple or complex congenital renal cyst. And for T, trauma or tumor, we have a Wilms tumor, a nephroblastoma, a diffuse hyperplastic perilobar nephroblastomatosis, the DHPLN, a retroperitoneal adrenal neuroblastoma, a clear cell sarcoma of the kidney, a rhabdoid tumor of the kidney, a lymphoma or leukemia with renal infiltration, a retroperitoneal teratoma for the T, and for inflammatory, idiopathic, and metabolic, no likely hypothesis for this
Okay,
case.
go to the ultrasound report.
Yes.
Okay, now question, what would you, no, okay, ultrasound report. Okay, now opinions from the people listening the conference, what to be. And again, Leonardo, what is the age of the patient?
11 months old.
11 months old. Okay, people, differential diagnosis that he presented and with the age of 11 months. And what is missing on this report of the ultrasound?
So on the chat, people are saying Wilms tumor, abdominal cysts. They want further image investigation with CT and contrast, and mesoblastic nephroma.
Let's also
Maybe,
talk about where is the comment on the other kidney.
yeah.
And then also obviously tumor markers and things like that. Yeah.
Yeah.
Okay.
Thanks, Mohammed.
Two differential diagnoses. One nephroblastoma, what to be the other possibility with somebody below the age of 1 year? People should put in the question mark there. Anyone to write. And what
They
is
put
missing?
mesoblastic nephroma.
No.
Someone put that, yeah, because that's more under 6 months.
Rhabdoid tumor is something to be considered without seeing the image. And the thing that's missing in the report of the ultrasound that's important that the radiologist should be doing is, do we have retroperitoneal lymph nodes? Yes or no? It's possible, very easy to see on ultrasound. You on coronal view, on the sagittal view, you look for the aorta, turn a little bit to one side, turn a little bit to other side, see if there are lymph nodes. Okay, go ahead, Leonardo.
So someone there asked for a CT, right? So
CT. Okay, stop there. Let me ask the question. Don't show the image. Go back one.
Okay.
Okay, you are the surgeon, everybody or the clinician involved, and the radiology place would ask, how do you want the CT to be performed? Who's going to answer this image, this question?
There was some answers about CT with contrasts. That was written.
And you want CT with
contrast.
IV contrast, and you want the IV done arteriovenous, portal, delay, or a single run? And would you do the chest together or chest tomorrow?
So the comments here, most of them said abdominal and pelvis to start with delayed imaging. Yeah. But the chest will come later on when we have more idea probably about what the tumor involves.
No, that's not the correct thing to do nowadays. The correct thing to do, since you are going to inject contrast and you are going to run the abdomen, we do the chest together in a single way. There is no question about, oh, I'm going to increase radiation to the patient. No. You see, a small patient, depending the place you are, you need to do sedation. Or if you do sedation, you are going to do 2 days of sedation. That's not a good idea. Therefore, and for the first examination in routine basis now for possible renal tumors, the thing we are doing now is encouraging radiologists to do the so-called split bolus. What do I mean by split bolus? You pick up the weight of the patient below the 1 year of age is 3 cc per kilo. Let's say if the kid is 9 kilos, okay, I'm going to do 27 cc, 30 cc, 30 ml. I inject 15, half, wait 10 minutes, don't do anything, inject the second half, and start from the chest down. I'm going to have the chest I have contrast, doesn't make a difference because I'm going to have the contrast in the abdomen. I go down until the pelvis like you want to have everything. And I have, at the same time, excretion to the collecting system because it's 10-15 minutes. Only for people to know, after 2 minutes of IV injection, 2 minutes IV injection, I have a contrast in the collecting system. 3 minutes, 100% of the time in the bladder. Since I'm doing between 10 and 15 minutes, I'm going to have all the ureters, the bladder of contrast. On the run that I inject contrast, I'm going to see vena cava, aorta, pelvis, chest, and everything, and will make the diagnosis of everything in a single run, no radiation, so on and so forth. Go ahead.
Perfect. In this case, it was not a split bolus CT, Professor, but we can see here the imaging, the axial section. I'll put it here.
Professor, can I ask a question about the choice of CT versus MRI? Obviously, some settings will dictate what you do, but if you have an options of doing both, what would your preference be and why?
Okay, my preference will be like this. Everything depends on the facility of the hospital. If you have the chance to do one or the other, see, at the beginning, okay, the majority of the places, they don't have the facility to do in the same day or next day an MRI. MRI would need more sedation, more everything. Therefore, regularly in the majority of the places here in Brazil and South America, it's easy to do a CT like we're seeing there. It's fast, you do in the same day. And nowadays with a 64 CT equipment, we wrap around the kid like this, okay? With a towel or something like there's a sheet, let the kid lying there. I have the vein puncture already. Don't need sedation. Sometimes I will give a lollipop or some sugar for the kid to chew when they are lying relaxed. Chew. We inject contrast and we do the split bolus. Depending the sophistication of the place, like you go to Europe, for example, on the European renal tumor, we have people doing the MRI of the abdomen, and they don't do the CT of the abdomen, and they do the chest CT. And nowadays we know that 5 millimeters lung lesion I can see on the MRI. Some place they do chest and abdomen and MRI. Therefore, easy way, majority of the places I will go for CT.
Yeah. Okay, so we have the pictures now for you to describe to us.
No, I want somebody else to describe. You pick up somebody else, give them the power of the phone, and Leonardo is going to run slowly, and somebody else will describe.
So if anyone on the Q&As want to start saying comments, otherwise I think we will probably have Hafiz as the first victim of starting to interpret the CT. But we'll see if people save Hafiz. Don't hide Hafiz.
So while Hafiz is there, I wanted just to make a comment that I learned from Professor Lederman also, that whenever possible, we have to be very mindful of preventing pulmonary atelectasis. Otherwise, we will not be able to see metastatic lesions. And in that concern, if possible, not doing a formal general anesthesia would help. But I know that this is not always possible, but just otherwise you will have the image and you will not be certain if
able to interpret. Yes.
Yeah.
So we have our first comment from Manan. Okay. Thank you, Manan. That there is a mass from the left kidney that is cystic with possible close sign, more like Wilms, and no thrombus. And she is not sure if there are lymph nodes involvement or not.
Okay, you said the one word cystic, correct?
That's what they said in the chat.
Okay. Leonardo, do you have the Hounsfield number or no?
No, I don't. Sorry, Professor.
Okay. Next time, in next meeting, we are going to discuss the significance for the surgeon and the clinician to have the knowledge of the Hounsfield number. That's the number that measures the attenuation of the mass. When we compare visually the gray appearance of the tumor with the gray appearance of the liver, they look more or less similar. A little bit darker on the tumor, but not so like a cystic. You see, when you do you have the bladder down there on the coronal? Okay, take the mouse to the bladder. There, you have the bladder. Don't need to run.
Here.
No, go
Sorry,
back
sorry.
one or two. Okay.
Yeah.
See, the bladder is cystic, is very dark. If you measure the Hounsfield number, this will be between 0 and 5. When you go for the tumor, this will be something like 30, 40. Therefore, this is a solid tumor, not a cystic tumor. Okay?
Yeah.
That's the major difference. Okay,
Yeah.
Dr. Simone, don't forget to ask me to give next meeting 2 minutes of Hounsfield number and significance of. We can ask Leonardo, that's fantastic presentation, to do it for me.
Of course.
Okay, noted. Thank
Yeah.
you.
Muhammad Ali said similar to what was just said, that this is solid because he compared it to the liver density. So
okay, great.
People are picking the same stuff.
Okay. Now, next, Leonardo.
So we have the report here and just some important information for surgeons about choosing from the ultrasound. We use it as a first line exam. It's available, it's quick, it's radiation free, and we do not require sedation for the kid. It can confirm the origin of the mass, such as renal, adrenal, retroperitoneal, and can distinguish from other causes, as we said, from hydronephrosis. With Doppler evaluation, we can see the renal vein and the vena cava for tumor extension, and it can identify solid or cystic components and necrosis. And for the CT here, we can confirm the local extent, monitor response for chemotherapy, for example. For chest, we can search for pulmonary metastasis. For abdomen, we can see the size for extrarenal extension and vena cava or rain involvement, lymph nodes, evaluate the bilateral disease, coexistent of urinary malformations, and as I said, intravascular extension. And if present, we can see the level of the thrombus and also if there is blood flow around it. So
you missed the lymph nodes.
The lymph nodes, it's here, Professor.
Where?
Abdomen, lymph nodes.
Lymph nodes.
Okay, lymph nodes. Yeah, lymph nodes should be in a separate line.
Okay.
Why it should be in a separate line, Leonardo? Because it will change the stage of the tumor.
Mm-hmm.
If you have lymph node involvement, you need to treat different. And okay, let's go for a question for the surgeon. Okay, we think this is a Wilms tumor. You are going to do the chemotherapy or surgery, depending if you are European style or American style. European, they go chemotherapy first. By the opinion of the clinical, surgical, and radiologic opinion, we say Wilms tumor. They treat chemotherapy, and they are going to do the follow-up after 2 sessions of chemotherapy, see everything is okay. How many lymph nodes should you remove? 0? Or who's going to ask? How the normal protocol, European protocol, the American, I don't know the number. The European, I know the number. How many lymph nodes we should remove during surgery? Any size.
They're saying 7 to 10.
That's the great. 7 is the lucky number.
Yeah.
I think they use this as a biblical thing. 7 days, 7 weeks, 7 something, 7 times, 7 years of growth. Somebody decided to use 7 as a biblical thing. Okay, let's go.
No, it's evidence science, Prof. But
Perfect.
Can I just highlight, we have probably 5 more minutes in this case, so we can go to the other, in case
okay,
you want to start talking about the management, Simon.
okay. Can we go further, Prof? Yeah.
Continue. So the laboratory, a little bit anemia. The white blood cells were okay. Normal renal hepatic coagulation profiles. Serology is negative. So about the professor saying SIOP and COG protocol, we have about Wilms tumor, we have the neoadjuvant chemotherapy against upfront surgery. Here we advocate for the SIOP protocol. So we start with a chemotherapy for 4 to 6 weeks, and then we perform the surgery until the tumor reduction, and then we can stratify by the histology and the surgical staging. The objective here is to reduce the tumor size, decrease the risk of intraoperative rupture, and facilitate complete resection. Despite the differences, both protocols achieve similar overall survival, up to 85 to 90% at experienced centers. So here we started with SIOP protocol, the European protocol, with 4 weeks neoadjuvant chemotherapy, and then we perform our surgery. But before the surgery, we need a preoperative imaging to see what happened to the tumor. So we have here axial section and coronal section. I'll go a little bit fast, but
Yeah. While Professor comment on the images, I'll just quickly say people are asking about do we get coagulation profile in every patient like this or not? What do you think, Simon?
Yes, we do. We always
Yeah, I
do.
think so. We do the same. Yeah.
And
Obviously,
also,
cases need to be discussed in an MDT, like they said, which is
yes,
what we're trying to do here, because obviously you need your radiologist, your oncologist, everyone to kind of,
yeah,
put you
and
on the
Okay,
same page.
Leonardo, stop in the middle. Stop this image. Okay, you see the tumor didn't decrease too much in size, but when we measure the Hounsfield number, we know, for example, we started with value of 50, 60, now it's 28, 30. We know the tumor respond partially treatment. Some areas are more darker, meaning some areas of necrosis. And there is one thing that I'm starting to use in the last few years, and still a major fight between the PSYOP group and everything. That's size is not a document anymore. Okay, you can have a tumor that does not decrease in size but had a lot of necrosis. This would change the volume of the tumor for treatment later on. Okay, go ahead because we are finishing our time, Leonardo.
okay.
just a comment about coagulation. Some Wilms tumor patients have von Willebrand-like phenomenon. So this can also be thought when you put a catheter in these patients, so be aware of that. So coagulogram is always important. Go ahead, Leo.
Okay, so as the professor said, virtually unchanged, but some heterogeneous solid and necrosis within the mass.
Go ahead,
So
please.
we perform the surgery. At the left here, we have the renal artery. At the middle, we have the renal vein. At the right, we have the ureter and resect it with a good margin. And what to know about the surgery. So it's a radical nephroureterectomy as a standard procedure. The goals are to perform and document a thorough surgical staging, achieve R0 resection, so total resection, prevent tumor spillage, and mitigate complications with an adequate lymph node sampling, as the professor said before, at least 7 up to 9 local regional lymph nodes. The nephron-sparing surgery is indicated for some patients at predisposition as bilateral Wilms tumor, solitary kidney, or horseshoe kidney. The tumor rupture should be avoided. The key steps are ensuring adequate access and gentle handling of the tumor. And For our case, the neoadjuvant chemotherapy aims to reduce the tumor volume and the risk of rupture. Caution about the superior mesenteric artery and the contralateral renal vein in cases the tumor crosses the midline.
There's a question in the chat, Professor, about the diffusion weight images, if you may.
Okay. Can we discuss about the diffusion? Do we have time, or this we leave for another?
Really,
Couple of minutes maximum, if that's okay.
Okay, okay. Go ahead with the image, click, 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 and we finish. And I'm going to discuss the value of ADC. Okay. Mixed cell tumor, go ahead. We don't need to do this classification now.
Okay.
Go ahead, Leonardo.
Histological classification, mixed type, staging, the surgical staging. For our case, stage 1.
Okay, go ahead.
Limited to the kidney, AV1 protocol of chemotherapy after the surgery, 4 weeks of chemotherapy, adjuvant chemotherapy, and then completed the treatment.
Okay. Dr. Simone, this presentation will be saved, and people can go and see later on this chemotherapy thing, correct?
yes, yes.
That's the plan, yeah.
For that.
Okay, the value of ADC. We learned in the last several years that the ADC is a number that it's a technical thing derived from the diffusion-weighted image. Every time the ADC value is low, what I mean low, for example, 600, 700, this will be in favor typical nephroblastoma, and with a low number, it's more favor the histology of blastema cells. When the value gets higher, could be a mixed tumor. And I'm going to give an example, very simple, that we're going to discuss one of these days when somebody will show. That's typical on neuroblastoma. Neuroblastoma, average is 600. You treat the neuroblastoma, you may have different areas, 600, 1,200, meaning that part of the tumor has maturated, part of the tumor still neuroblastoma. Therefore, I have a combination neuroblastoma, ganglion neuroblastoma. On Wilms tumor, I may have some that will be blastema, some of them will be the mixed type with different two cellularities. Okay, there is a good article that I was part of this group done by the people from Holland, and I can find later on, give to Simone, she can put the revision. This was a major PhD thesis of somebody on oncology that measure all the ADC and discuss the value, so on and so forth. ADC, you can use in everything. For example, brain tumor. Medulloblastoma in the brain posterior fossa has a very low ADC value. On the other side, an ependymoma has a little bit higher, and a blastoma, glioblastoma, astrocytoma higher. Meaning, if you have a lesion, you put the ADC value, oh, that's too low. That could be medulloblastoma, cellularity proof. Okay, therefore, and it goes for everything. It goes on Hodgkin disease, for example, when you treat the patient and there is residual mass, you go and see the ADC. The ADC is high or very high, this is fibrous. The ADC is still low, that's remaining tumor. Okay, therefore, we can use this in every tumor. Okay, go ahead. We finish.
Just a comment. There is another important question, I think, from Mahmoud about if you have a renal tumor in an atypical age for Wilms, can radiology tell us if it's likely Wilms or not?
You have this paper, Dr. Simone. 99, 98% of the time we're correct, because we use everything. We use the Hounsfield number or the ADC number. We use the malignant vascularity. We use the age. We use everything, and 98% of the time we are correct. And 98, 97. She knows better than I.
Yeah, 98.1. But I just wanted to comment in this situation, if you are in doubt, and if the tumor is resectable, you should resect and not give chemotherapy, because the image or the age are not adequate for Wilms tumor, right?
Okay, you see, if you are in doubt and the tumor is easily resectable, you can go for resection.
Yeah.
If the tumor is big, the age could be Wilms, could be a different one. There is no major damage to the patient for you to do the 4 weeks chemotherapy and wait for a week and see if the tumor shrink. If the tumor shrink, you are in better shape for the surgery. When the tumor is easy to be operated and you are in doubt, I think we move to the USA style, go for surgery.
Yeah. Thank you, Leonardo.
I think we need to move to the next one, yeah?
Yes, we will maybe in the future bring some special situations on Wilms tumors, like bilateral or vascular extension, but today that was our case. Thank you, Leonardo, for presenting.
Thank you, Leonardo, so much. Thank you, Professor.
Yeah.
Thank you very much.
And we can go ahead with Hafiz's case. Please, Hafiz.
Thank you for the opportunity to present this exciting case. This should be shorter, for sure. Let me share. And can you see my slides?
Yeah, everything's good.
One slide or a couple of slides do you see?
We can see everything. You're good.
I just wanted to make sure that I'm using one slide or two slides to present.
I see
You
one
are
slide.
on the presentation mode. Okay, Alfes. Go
You
ahead.
see?
It's perfect.
Okay, perfect. Good. So this is an 18-month-old female with no significant background history except for prematurity, who was noticed by her grandpa to have an abdominal mass, incidentally. And so he took her to the primary doctor.
You think this is upper abdomen or lower abdomen? You didn't tell us.
It was actually a very large mass. And then the physical examination confirmed the grandpa finding that it's a huge mass that is likely right side, but it's occupying the entire right side of the abdomen and crossing the midline as well.
Okay, and we have a elevated SAT, elevated alkaline phosphatase, and alpha-fetoprotein. 10,000 for 18 months is very high.
Yes.
10,000 could be for the first few months of life. Yes. Okay.
So this was alarming to the primary doctor and the treating team. And so she was sent to the emergency department.
Okay, go for the ultrasound.
Yes, so they started with an ultrasound, followed by a CT scan, and then followed by an MRI the next day.
Okay, now we are going to discuss. Show the ultrasound. Go ahead. Do you have the image?
I have the image, but I thought that maybe I'll just show the CT scan. The ultrasound didn't show much because it was just a huge mass everywhere, lobulated, crossing the midline. They thought it's a neuroblastoma on the ultrasound report.
Okay,
so
hold on. Stop there.
Yes.
Did they have the alpha fetal and before the ultrasound or not?
I think probably the ultrasonographer was not looking at the alpha. It was not ready yet. The result was not ready yet. So
but you see, for in the real life, as people would do on the same day, they would ask for an ultrasound, and they are going to go for a lab examination at the same time. They will do both at the same time.
Correct.
Therefore, even with the radiologist that did ultrasound said that could be a neuroblastoma, if the lab examination of the alpha fetoprotein came early, I don't think we are correct in diagnosis.
Absolutely.
And this is important because you need to do a CT in a specific technical way, different than that we did in Wilms tumor. Because you see, I think this will be a liver mass. If it will be a liver mass, okay, let's ask how people do the CT if this will be a liver mass because of the alpha fetoprotein. Let's see the questions. Q&A.
So far, people suggested liver mass, but they didn't say anything specific about CT modalities. So let's see if someone say something different. So your question, Professor, is how the CT technique is different if you are suspecting that this big massive mass is related to the liver.
Yes,
so
that's the question.
First question, triphasic with arterial, venous, and late phase. That's one of the people. Another one, portal and arterial and venous CT with contrast.
Okay. Do people are going to use oral contrast or only IV contrast? Question mark number 1.
So far, the ones we had were talking about IV contrast. To
IV
see
contrast,
if
okay.
someone add orals. Yeah, IV, the ones we have so far.
Okay, you see, if I know by the ultrasound that this is not abdominal, that's liver, I do not use oral contrast because the oral contrast is going to interfere with my quality of liver CT. Okay, since I'm going to do multiple phase and I don't know the etiology, let's say I don't have the alpha fetoprotein yet. This could be hemangiomatosis, could be differential, different things on this on this small baby. Okay, therefore, nowadays, since I'm going to do a CT, I plan the CT with the so-called multiple phase, but nowadays I'm using 5 phases. Why 5? I use the first one without contrast. Localize everything. I know the field is perfect. I inject the arterial, venous, parenchymal, and delay. Why I go for delay? This could be a diffuse hemangiomatosis, and I can see the filling of the tumor slow or the filling of the tumor fast, empty fast, or slowly filling, and at the end of 2 minutes, that delay phase is 2 minutes, mean 0, non-contrast, 30 seconds, arterial, close to 60 seconds, venous, close to 90 seconds, more or less, the parenchymal phase, and 120 the delay phase. Okay? That's the fantastic, good protocol you never lose. And don't forget nowadays, with good technologies, low radiation, you can do this examination. Don't worry, because you are facing a tumor, something like this, and the precise diagnosis is 100% better than the wrong diagnosis. Okay, go ahead.
All right, good. So I'll go ahead and share then the CT scan. All right.
Okay.
Skull on both sides.
Okay, now stay like this. Now I know why somebody said that could be a neuroblastoma, because it's difficult to see the relationship between this and the liver. Go ahead on the actual view. Stop there. Oh, go back to one more. Okay, stay there. Do we see the adrenal gland? On the left side, there is a small tiny arrow there. On the right side, I see the long leg of the adrenal gland. Go ahead.
This is where it ends.
The other side.
This is where it starts.
Now you see the tumor involving. Leonardo, you want to discuss this? Go ahead, Leonardo. Have fun. First, go more, one more. To the other side, other way.
Below, yes.
Okay, one more. Stop there. Leonardo, go ahead.
It seems a liver tumor, and I think we can see the porta vein over there. It's a little bit heterogeneous mass. And what else do you want me to say, Professor?
Now, you see on the coronal view, you see a hepatic vein go inside the cave.
Yes.
Okay, let's
Yes.
go. Go further the image, FS.
Go for
Go down.
down. Okay.
You see this central is hypoattenuating. Okay, and okay, you see there is vessel inside. What to be the secret on this image that we need to follow very carefully when we are reporting and the surgeon is looking the portal vein, the hepatic vein, see how they go. The portal vein and hepatic vein are most important. Okay.
So I can maybe show the hepatic. They are a little bit far away from the
Okay,
tumor.
see, go back. Well, stay there. You see,
Yes.
I can see the right, middle, and left hepatic vein coming to the IVC. Okay, Leonardo, with the alpha fetal this way, do you think you need biopsy?
I don't think so.
Nowadays, yes.
Okay.
Because there are three cellularities on hepatoblastoma.
Molecular, yes.
One that will be responding to chemotherapy, one that would not do chemotherapy. And even there is a paper, recent paper on the so-called radiomics and radiogenomics, that depending the type of the image, you can guess the cellularity, because they prove this on biopsy. And I'm going to find this paper, sent to Simone for her to put for the colleagues to read it. Okay, we are almost close at the end of the time. Go ahead, Afes.
So basically,
okay, hold on. Let me ask a question to Leonardo. What do you expect from the radiology report?
I'll expect him to give me the pretext.
Okay, what is the pretext? What's the significance of this?
It will give me the sections of the liver that are free from the tumor.
And the pretext I do before chemotherapy.
Yes.
I do the chemotherapy, and do I do again a post-test?
Yes.
You know, what's
For
the
the
major
surgery.
difference? What's major difference? Why I need to do both?
You have to know it if there is a response to chemotherapy. And
Okay. I say the tumor shrink a little bit, decrease in size.
And if you give me a post-text 1 or 2, we can probably perform the surgery. But if we are talking about a post-text 4, we are talking about a liver transplant here.
Okay,
And
post-text means I look the vessels, the portal vein, and the hepatic vein, and I look the segmentation. Okay, like you said, I have segmentation. A small closed area, I know I can cut it and done. I have one area here, one area there, I cannot do it. That's the thing you're saying, correct?
Yes.
Okay, go ahead, Afes.
The question I'll pose now is, what is the pretext that you will assign for this patient?
Leonardo, for you. This is a good patient or a bad patient for the surgeon? Only from the image, on this image. You see the three veins there.
Yeah.
The tumor is more peripheral.
Let me see again all the CT, please.
Yes, absolutely. So this is you know, this is the tumor. You can see it. I'm going to show you the portal veins because the relationship with the hepatic veins is not complicated. It's far away from the origin, but the complicated part is the relationship to the portal veins.
Yes.
Yes. I think it's a bad case for upfront surgery. Maybe a little bit of chemotherapy here.
Do you prefer, that's a question for everybody, prefer to do surgery right away if there'll be like pre-test 1 or 2, or you always prefer to do chemotherapy that will help you, the surgeon, to decrease the size of the tumor? Like in Wilms tumor, they sometimes do a small capsule, so on and so forth. It's easy for the surgeon. Let's see people answering this question.
So, no answers yet?
No answer. First, since we are going short of time, you can comment, please.
Yeah, so basically the reports and multiple radiologists looked into this image, thought the tumor is originating from segment 5 and it's exophytic and it's large and it's pushing on the vessel. So in terms of pretext, there is only 2 sectors that are free of the disease, which is the left sectors, the medial and the lateral. But you know, so that will make it pretext 2. However, the distance between the tumor and the portal vein was very small, maybe a millimeter. To go for upfront resection, we normally want a centimeter difference to ensure a good margin to do an upfront resection before even biopsy. We can do upfront resection for pretext 1 and pretext 2. So the decision was to then go for a biopsy for a pretext 2. And that's what was done. And the tumor was really good histology, a pure fetal histology, well differentiated. I have to mention also the CT chest, there was no metastatic disease. So then the patient received only 1 agent, cisplatin chemotherapy, received 2 cycles, and then image was repeated afterwards. And because of the time limitation, I can either show that the image or say basically there was no change. It stayed the same, surprisingly.
And does the change, can I ask Hafiz a question? The change in terms of the size was no difference, but was there a difference in heterogeneity or necrosis? Like Professor was saying that this sometimes can mark a response, or there was no changes even in necrosis?
Great question. No, it was the tumor already had a lot of necrosis to start with, even before therapy. So there was no much change whatsoever.
Yeah.
Tumor. And we were really shocked because hepatoblastoma, well-differentiated fetal histology, it should do really well from chemotherapy standpoint.
Yeah.
So what would you do next then? That's the question. Now we have this pretext 2, with close relationship to the portal vessels, and 2 cycles of chemotherapy, and the response was, any
lung metastasis? No.
No lung metastasis.
Okay, Leonardo, you may start crying or calling the team for surgery.
You are a radiologist. You will say, "Oh, it's easy. Just cut here, and it's all right."
Yeah, okay.
But we are surgeons, and we have to discuss it multidisciplinary with oncologists and decide what's the best for the patient. Or if it's the surgery up front, the surgery, or thinking about liver transplant.
So what did you do, Hafiz?
Good. I'll share a slide. We said, well, we have to bite the bullet and go ahead and resect it. Even if you get like a margin of a millimeter, if you get like a preserved Gleasonian sheath or something, around the vessels and use that as a margin, open the Glisoni sheath, maybe we'll be able to get a margin. And so we went ahead and operated. And then there's another surprise that we found intraoperatively. As you know, all the reports were saying segment 5. The MRI was also saying originated from segments 5. And then, we went in. Obviously, our patient fit the low risk because it was not resectable, but it has like all other favorable.
Yes.
Pretext 2, yes,
Mm-hmm.
other favorable findings. And then these were the cycles. The alpha-fetoprotein was going down, but the tumor size was not going down. And this was the repeat MRI, which had no significant change in size. And we found segment 4 to be involved heavily also with the tumor. As you can see, the falciform ligament here, the tumor is like on the other side as well. We have missed seeing that in the CTs and MRIs. We thought it's an external compression, but this was actually pretext 3 now.
Mm-hmm.
2, and we ended up doing a mesohepatectomy. You can see we took the anterior branch of the right portal vein. You can see the posterior branches here. And then we took the blood supply to the segment 4B. And that was how we achieved, actually, it was a really good large margin of normal liver that we were able to resect with. So the margin was not closed. And then the patient is still inpatient. As you see, I just did this procedure. And she's going home today.
Fantastic.
Fantastic.
Very
Congratulations.
good.
You made the surgery look easy, Hafiz.
Yeah, it's yeah, you need to be confident. That's important. Fantastic. Thank you very much for the opportunity. Later on, people discuss and give the opinion for Dr. Simone to discuss with me if this is the idea to give this conference or not, or we change something different. And the most important thing, since this is recorded, when we have more slides, we should go slowly, putting every slide on the screen for this to be recorded for everybody. Okay?
Can I ask people to try and write if there is any comments overall, not on the case particularly, on how we present this, because we tried here to make the focus more on the radiology, because I know a lot of people in different countries interpret the image themselves. So we wanted to make sure the radiology part is well covered in terms of, what an experienced radiologist would look for. So then you can help yourself if you are in the situation of needing to look at the images yourself. So if there is comments about how it was presented, or if there is more or less information you would have wanted, please write to us in the Q&As, and
also by email.
And also by email.
Yes.
Yeah. We'll give a couple of minutes for people to write any comments on the session overall. But I really want to thank everyone, because this was, very, very well done. We have live case that is, we have it as it's been operated. If the meeting was yesterday, we would have not seen the case. So I'll give another minute to see comments from the people.
And Dr. Simone has some budget for our administration to have a camera, okay? How come the administration without a camera? That's no good.
Yes, I agree, totally.
Poor Mohammed. He's on vacation.
I'm on holiday. I'm doing this from the beach.
He is. Yes, he is so committed.
I thought it need to have the spirit of.
Okay. Therefore, next month, I hope you are not on vacation. And
No, I will work hard. I promise. Next meeting, I think the plan is to be a radiologist. Sorry, a urology radiology meeting. So yeah, I'll be
Whatever.
definitely working.
The subject is up to you and
Yeah.
Simone, okay?
Yeah.
So I don't see comments from the people. It's a useful discussion. Thank you everyone for attending. We hope this was useful for you. It certainly was for me and for us. And thank you so much, all the presenters, Professor Lederman, Hafiz, Leonardo, Simone, and Anand. He was in the background making sure everything is all right. So thank you, Anand. So I think we will close the meeting.
Yeah, thank you so much. I'm just answering some things on the chat.
Is there before we close?
No,
Yeah.
just yeah. But I think I could answer all of those. Yeah.
Okay, thank you very much for the opportunity to have fun with the surgeons.
Yes,
thank you so much, Professor.
Bye-bye. Have a nice week, everybody. Bye.
Thank you. Bye. So, Simone, I'll stop the whole meeting then, which will close this. Is that okay?
Yes. Thank you, Mohammed, and thanks for joining. Yeah.
Thank you
all for your support. Yeah.
Thank you. Bye. I'm trying to figure out how to close it.
I can do that, I think.
Can you do that from your end? Yeah.